Symptoms: disturbed coordination, affecting amplitude and velocity of intended movements, and sparing strength. Tremor may be present. Hypotonia, in some cases but usually mild. Truncal ataxia, unsteadiness in sitting, standing, or walking, titubation. Limb ataxia, often accompanied by tremor. Other symptoms depending on etiology, e.g., headache, neurologic deficits. Recent infection or immunization, e.g., resolving varicella. History of medication use, e.g., antiepileptic drugs. Signs: sensory ataxia. Areflexia, with diminished proprioception and vibratory sense. Romberg's sign, exacerbation of truncal instability with eye closure. Cerebellar ataxia. Truncal, hyporeflexia, unsteady stance or gait. Romberg's sign is absent. When severe, sitting and/or speech may be affected. Appendicular, limb dysmetria and dysdiadochokinesia, impaired rapid alternating movements, ipsilateral to the affected cerebellar hemisphere. Signs of raised intracranial pressure. Other neurologic signs according to etiology: altered mental status, cranial nerve palsies, hemiparesis, sensory deficits. Skin lesions, e.g., evidence of resolving varicella. Investigations. Investigation may occasionally be deferred, e.g., classic, acute cerebellar ataxia. Clearly following a bout of varicella, additional studies are often required. Neuroimaging, cranial CT, MRI, or MRA for tumor, vascular malformation. Hydrocephalus, vasculitis, and generally performed prior to lumbar puncture. Toxin screen of urine and/or blood, for drug intoxication. Blood chemistries, including ammonia, pyruvate, lactate, and urine amino and organic acids, for inborn errors of metabolism. CSF analysis, for infection and post-infectious syndromes, e.g., Guillain-Barré. Antibody titers against specific infectious agents, Mycoplasma, Epstein-Barr virus. Nerve conduction studies, for Guillain-Barré syndrome, early, absent F waves may support diagnosis. In 1WK most patients show slowed or blocked nerve conduction. Complications: herniation of the cerebellum, upwards or downwards, in cases of posterior fossa mass lesion. Respiratory failure, in Guillain-Barré syndrome. Complications of drug ingestion and inborn errors of metabolism, e.g., cardiac dysrhythmia with severe carbamazepine intoxication. Differential diagnosis. Ataxia must be distinguished from vertigo, e.g., acute labyrinthitis, paroxysmal vertigo of childhood, spinal cord syndromes, transverse myelitis, tumor, vascular malformation, orthopedic disorders causing gait instability, acute intervertebral discitis, toxic synovitis, typically involving the hip, or septic arthritis. The latter syndromes are usually accompanied by pain and fever. Sydenham's chorea. Opsoclonus/myoclonus syndrome may closely resemble cerebellar ataxia treatment. Diet and lifestyle. Specific inborn errors of metabolism require appropriate dietary restriction and/or avoidance of certain medications, e.g., low-protein diet in hyperammonemia. Syndromes. Pharmacologic treatment. Intoxications should be managed according to the offending agent. Bacterial infections require appropriate antibiotic therapy and/or surgical drainage. In ADEM, steroid therapy should be considered. Controlled trials are lacking, and not all patients respond, but anecdotal reports strongly support the notion of a steroid-responsive subgroup. In genetic disorders causing episodic ataxia, specific therapies, such as acetazolamide, may be effective. Non-pharmacologic treatment. Surgical intervention in posterior fossa tumor, expanding hematoma, abscess. Empyema, Dandy-Walker cyst. Radiotherapy, and/or chemotherapy, in selected patients with malignant posterior fossa tumors. Treatment aims: To promptly and specifically manage disease according to etiology. To prevent recurrence in intermittent ataxia. Prognosis. In post-varicella ataxia, complete resolution occurs in nearly all cases within 3 to 5 weeks. Recovery is less predictable. In ADEM, cerebellar astrocytoma can often be managed definitively by surgery alone. With excellent outcome, prognosis is variable with other posterior fossa tumors, which may require irradiation, chemotherapy, or both. Follow-up and management. Acute ataxia is usually a monophasic illness, and follow-up is based on the etiology. If deficits persist, physical occupational therapy is indicated. If no cause is evident, careful follow-up. For recurrence, which would suggest metabolic disease, is required.